Okay, good morning. It's again Friday, and on Friday, what do? We're celebrating vision research, and as you know, imaging is incredibly important because if we can see the changes of interest and follow pathologists, that's really very important. And as it happens, we have one of the leaders in this field, Dr. Marcos. She took over after David Williams in Rochester, if that's correct. I am not sure, but so this again suggests immediately how wonderful scientist Dr. Marcos is. And we're very, very delighted to have her today. And hopefully we will learn more about imaging. Thank you so much.
Hello and good morning. My name is Hernan Gomez, and I am a second-year graduate student in Dr. Palczewski's lab here at the Center for Translational Vision Research at the University of California, Irvine. It is my pleasure to introduce today's distinguished speaker, Dr. Susana Marcos. Dr. Marcos received her Ph.D. in visual optics from the University of Salamanca. Following this, she underwent pre-doctoral training at the Instituto de Óptica in Spain, and postdoctoral training at the Schepens Eye Research Institute in Boston, Massachusetts. She is currently on leave as a professor of the Instituto de Óptica and director of the Laboratory of Visual and Biophotonics Optics. As the current David R. Williams Director of the Center for Visual Science at the University of Rochester, she has published more than 200 highly cited research articles, inventor of 23 patents, co-founder of 2 companies, and has given more than 200 talks at various international conferences. She has received many awards throughout her career, including the Adolf Law Medal, Alcon Research Institute Award, and the National Research Award in Engineering from the government of Spain. In addition to her many scientific achievements, she has various roles in groups such as the Optical Society of America, Spanish Society of Optics, and the Scientific Culture Editorial Board. Dr. Marcos' current research seeks to understand the interplay of structural, biomechanical, and optical properties of the eye, their impact on retinal image quality, and their effects on visual function and perception. This is achieved by using images and modeling to understand, simulate, model, and probe basic mechanisms in corneal disease, lens aging, and myopia in order to optimize and design new ocular treatments. Now, please join me in welcoming Dr. Susana Marcos for her talk, Quantitative High-Resolution Imaging of the Anterior Segment, Applications in Prevalent Eye Conditions.
Well, thank you very much. It's really a pleasure to be here. I mean, this distinguished speaker series I've heard about. I mean, it seems a wonderful opportunity to meet lots of people interested in the eye and interested in translation in the eye and interested in imaging. As mentioned, and I'm really thankful for the words. I am currently the David Williams Director of the Center for Visual Science, and I hold professorships at the Institute of Optics and the Flaum Eye Institute at the University of Rochester, New York. Part of the work I'm going to present was actually done over the years with multiple collaborators and at the Institute of Optics in Madrid. A few disclosures there, including the 2 companies that that have been mentioned. I have been a co-founder or shareholder, Twice Vision and Planoptica, and work that we do with multiple companies in the ophthalmic space. So the eye, of course, is a wonderful imaging device by itself, and it has the cornea and the crystalline lens that projects the images of the outside world on the retina. So I'm mostly interested in understanding the cornea and the crystalline lens, their quantitative properties, both optical, structural, geometrical, mechanical. and how those interplay to set the image quality of the images that are projected on the retina. It's interesting because in any manipulation that we do in the eye to correct some of the prevalent conditions that affect the anterior segment, we actually, what we do is we manipulate those elements, right? We can reshape the cornea to correct for myopia in a refractive surgery procedure, or we change the crystalline lens by an intraocular lens. Basically, what we're doing is we're modifying the structure, we're modifying the geometry, sometimes even the index of refraction of those elements. And what we do is, that has a consequence on the image on the retina. Although today I will be concentrating on the techniques and applications that allows us imaging and quantifying the cornea and the crystalline lens. There is a big part of my lab that what does is really trying to connect the image quality that is of the images that are projected on the retina with visual perception. Again, we use techniques that probably many of you are familiar with, adaptive optics, in this case, not for manipulating or correcting the aberrations to get sharper images of the retina, but actually to manipulate the images and see what is the effect it has on vision. But this, you'll have to invite me some other time to cover that aspect. I will be instead covering a series of imaging technologies and applications. And those images include OCT, so fully quantitative optical coherence tomography in the anterior segment of the eye, that allows to assess the cornea and the crystalline lens, and even dynamic processes in the eye, such as the lens accommodation, as you see here. I will also be covering, of course, aberrometry. That's how we measure the aberrations of the eye, that, as you'll see, they're a consequence of these geometrical and structural factors of the cornea and lens. I will also be covering, an additional aspect of OCT, in this case, adding stimulations to generate corneal biomechanical properties and corneal biomechanical maps, and also high resolution imaging, including multiphoton microscopy, in particularly second harmonic generation microscopy, that allows us to target or to measure the arrangement of the collagen fibers in the cornea and also in the sclera. The conditions I will be briefly covering include keratoconus, which is this disease that produces a protrusion of the cornea, and this has a biomechanical background. There is a loss in the integrity of the mechanical properties of the cornea that lead to a deformation in the cornea. So it's biomechanics translated into geometry, and that produces very distorted images in the retina of the patients. I will be covering cataract and presbyopia. These are age-related conditions. Cataract affects about 50% of the population over the age of 70. Presbyopia is an age-related condition, occurs earlier in life, affects 100% of the population over the age of 45. So very prevalent conditions related to the aging of the crystalline lens. And of course, we can modify the image quality by replacing the crystalline lens by an intraocular lens. And finally, myopia. So myopia is a condition that is increasing in prevalence. Some areas of the world, as you may know, in Asia, in Singapore, Hong Kong, urban areas in China, the prevalence of myopia is 90% of the population. And that's actually increasing everywhere in the world. And it's expected that those numbers will reach Western populations by 2050. And you will know it's a condition by which the eye grows excessively, so that the cornea and the crystalline lens do not focus on the retina, but actually in front of the retina. It's like eye has grown too much, exceeding the power of the optical elements. So I mentioned about the aberrations of the eye, and this is actually something that varies across the population. This is just a subsample of wave aberrations obtained from aberrometry, where you see that there is a kind of a fingerprint. Different eyes have different distributions of aberrations, also different magnitude. And those are normal subjects. Of course, this changes even more in pathology. The way that we understand these optical aberrations is actually because we have lenses that have a certain geometry, and we are using and developing technologies around anterior segment OCT to actually measure these geometrical properties of the cornea and the crystalline lens. The data I'm going to show relate to two different OCT systems, spectral OCT that we developed years back in collaboration with Magic's group, and then more recently Swissor's OCT. Of course, they vary in sensitivity and particularly high. I mean, the acquisition rates. The current Swissor's OCT that we are working with has an acquisition rate of 200,000 A scans per second. Of course, with OCT, you can get really nice images, but for the purposes of the applications I'm referring to, quantification is key, right? We really need and want to have these three-dimensional accurate biometry information. And to do that, we've developed a number of image processing algorithms and that include, among others, automatic segmentation, identification of the different elements in the anterior segment, and very importantly, distortion corrections. There's two types of distortions that occur in anterior segment OCT. One arises from the scanning architecture, the fact that the two scanners are generally separated by a distance, and therefore there is astigmatism. I mean, generally, if you put a flat mirror in front of your OCT system, at least in one of the orientation is going to be curved, and you need to correct for that. And the other is the fact that you're viewing refractive elements through refractive elements. So there is a optical distortion or refractive distortion that we are correcting in 3D. And doing this, you can go from images to actual output data that are topographically, tomographically, and biometrically correct. And this is the type of information that we can get, right? You can have this anterior segment image that is now fully corrected, so that you can get topographies of the cornea, but also topographies of the crystalline lens that are not typically obtained. Can get phakimetry, pupillometry, anterior chamber depth, lens thickness, lens tilt, and decentration. So we can have from the same image this full information that we can actually plug into model eyes, for example. The an application of OCT in keratoconus is shown here, where we're using OCT to measure the anterior and posterior corneal topographies, but also in this case, in pre and post-op intracorneal ring segments. So this is one of the alternatives for correction of keratoconus, where intracorneal ring segments are implanted in the periphery of the cornea to support the cornea and to produce some flattening and regularization of the corneal topography, which you see here that was achieved, right? When we have this topographic information, we can actually do a ray tracing now virtually, and we can obtain the wave aberrations of the cornea and look at parameters that relate to the retinal image quality, now that we have the wave aberrations from the geometrical information. So once you have, let's say, the topography and tomography of the cornea in keratoconus, and you have the geometry of these intracorneal ring segments that you can implant, you can perform models, right? And the model would tell you how the cornea reshapes, or was the response of the cornea to such implant. And you may even want to select the implant that actually produces the change of curvature that you want, or the change in power, or the regularization that you want. So those are exercises that we did, and they're shown in this paper here. But of course, there's one key piece of information missing, which is the mechanical properties, right? I mean, intuitively, you may think that the response of the cornea to those rings is going to be different if the cornea is stiffer or softer, or if it has regions, as it happens in keratoconus, that have localized weakening. So it became apparent that for this application, or many other applications, including creating incisions in the cornea, or removing like layers of the cornea, or cross-linking, as we'll see, we should know the mechanical properties of the cornea for proper surgical planning. As part of an European consortium called Customize, we developed a number of techniques that actually are aiming to, on the one hand, produce a biomarker for keratoconus, now based on mechanical properties, and second, create mechanical maps that can be used for the purpose of surgical planning. This is one of those instruments that was collaborative work with Maciej Wojtowski's group, where we were actually now combining OCT, and this is a Swiss source OCT, with ERPAF in multiple meridians. So this is done with, I mean, a coaxial ERPAF, an obstructed view, and looking at multiple meridian deformation. This was actually already in previous work, where you can see here back in 2011, where we were combining this ERPAF, and you can see this deformation of the cornea that after, for example, a procedure of cross-linking that aims at stiffening the cornea gets reduced. Of course, you can combine this deformation and these experimental values with simulations, finite element model simulations, to actually derive the mechanical properties that would produce that deformation. This is shown here for a human cornea, in this case in vivo, where dotted lines represent the experimental deformation. In the left side is the apex indentation, so looking at the apex of the cornea. In the right plot, you see the B scan getting deformed. And what you see is how the mechanical properties that we reconstruct, in this case, the Young's modulus and viscoelastic constants, can reproduce the mechanical deformation. And we made sure that those are unique values that are not falling into local minimum in the optimization. So now, as you can go with OCT and produce these biomarkers that relate to the mechanical properties of the cornea. So it can be biomarkers looking at deformation asymmetries. For example, here in this graph, we show the asymmetry of the displaced area in a B scan in the vertical meridian and the horizontal meridian, showing that in a keratoconic eye, you will have a deformation that occurs primarily, or the asymmetry that occurs primarily in the vertical meridian. As I said, we can also produce these mechanical properties where now we have the mechanical stiffness of the area of the cone that is weaker than the periphery of the cone. So corneal deformation using ERPAF, producing a deformation of the cornea as a stimulus, and getting as outputs not only the geometry of the cornea, but the mechanical properties of the cornea, or biomarkers for deformation and asymmetry that will detect or help to detect keratoconus. So we can use other type of excitations in the cornea. And in this case, we're using exactly the same anterior segment OCT, sweat source OCT, now in a phase-sensitive modality and in combination with ultrasound excitation. So here, in this case, we have a transducer that it's an air coupled transducer that perturbates the apex of the cornea. And we look at multiple meridians. And in this case, what we're looking at is the Lamb wave that travels throughout the cornea, the speed of those waves being proportional to the serum modulus of the cornea. So because we're doing multiple meridians, we can create that this type of multi-meridian polar plots that indicate the speed of propagation across the different meridians. Those meridians that have or show a higher speed of propagation, or those locations that will show a higher speed of propagation will be indicative of a stiffer regions of the cornea. However, in those locations where the wave slows down, there will be weaker areas in the cornea. So we can generate both these plots or maps. And here you're seeing in the maps are actually the cases or the examples of an eye with a keratoconus, where you can see this region of more elastic or lower speed of propagation. And also we can look at the contralateral eye of this eye, where it shows an area where, you know, it's not completely homogeneous. It starts showing a cone. What is interesting is that this cornea doesn't have any topographical sign or tomographical sign. So from a structural point of view, it's normal. We know it's likely to develop keratoconus because the contralateral eye already developed keratoconus. But what the technique is showing is an early indicator of keratoconus in this eye. So we can look at the maps, we can look at the plots as shown in the left part of the graphs, where the blue points here represent the Lamb wave speed as a function of corneal thickness in a normal population. So all those points are from normal corneas. And what you see here are in the upper graph. In green is a stage 3 keratoconus, so the eye of a keratoconic patient that has developed keratoconus, and you see big asymmetries, reduction, not necessarily only in the thickness. The thickness may be comparable to normal eyes, but definitely in the Lamb wave speed. And also in red is the contralateral eye. This is a preclinical keratoconus, but you see that there's a few spots here that are actually getting out from the normal region. Here, there's two cases of, there's another case of a keratoconus, green, very off the normal range, fully developed keratoconus. And then these preclinical keratoconus where you see, in this case, the corneal thickness is below normal, but also the number of spots that are outside of the normal range. The lower case is an eye that has keratoconus in both eyes, and look at how big asymmetries you find in this patient. So OCT combined with ultrasound, allowing us to detect keratoconus at an early stage, not only from the topography and the geometry of the cornea, but also from the these mechanical biomarkers. Another treatment for keratoconus is cross-linking. In cross-linking, what is explained to happen is that in these corneas that have areas with weakened corneal structure, cross-linking may create covalent bonds between collagen fibers, and that will stiffen the cornea. The Dresden protocol uses riboflavin, which is a photosensitizer, normally in dextran, and then it's followed by 30 minutes of irradiation with UV light. And this is what, in a rabbit model eye, but using the Dresden protocol, this is what our corneal biomechanical maps using this ultrasound excitation OCT show. So you see the maps pre-treatment, And then the lamp speed increasing, meaning a stiffening of the cornea all throughout after cross-linking. In terms of shear modulus that we derive from the lamp wave speed, you can see these increase in the shear modulus after cross-linking. We cannot tell yet whether the cross-linking is truly creating these covalent bonds within collagen. It may be also that is stiffening the hydrogel where those collagens are embedded, right? The extracellular matrix, but truly there is an increase in the mechanical stiffness. So if we want to look at collagen fibers, a really nice technique to do that is second harmonic generation microscopy. And this is a technique that we have developed in our lab for the purpose of looking at the scleral corneal and scleral and corneal arrangement of collagen fibers. This is a multi-photon technique, and specifically in the second harmonic generation emission, we're looking at emission that is produced by non-centrosymmetric structures, and this is what the collagen is actually. And for some reason, the 3D movies are not showing, but this is a typical example of the arrangement of the collagens in an eye. The red dots are actually fluorescence mode for the photosensitizer. In this case, the photosensitizer is rose Bengal that we're using as another modality, like alternative to the Dresden protocol that uses riboflavin and UV light. So it's interesting to look at this collagen organization. These are examples from human corneas, control eye, where you see that the collagen is finely interweaved. And in keratoconus eyes, these are samples of the cornea that is taken out from keratoconic patients that underwent penetrating keratoplasty procedure. So we're using the pieces of cornea that are taken from those patients. And what you see is that the collagen arrangement is pretty different, right? Here, what we see are bundles of fibers that are more parallel and that have lost much of this interweaving that we observe in the control corneas. And don't forget these type of images, because we'll see those types of images in another application that will be showing towards the end of the talk. So in cross-linking, what we found and what we can analyze and obtain markers for the rearrangement of the cones is that in the region of the volume of the cornea that is affected by cross-linking, in this case, showing here data of the collagen arrangement in an eye before cross-linking, and then after riboflavin, and then after irradiation with UV light, you see that there is a region here where this parameter has increased. Which is where the procedure has taken place. So we can look at different ways where, of how the cross-linking is affecting the cornea. We can convert the Young's modulus that we obtain from corneal deformation into a stress strain curves. And what you see is that, and these are treatments in vivo, that there is an increase in the Young's modulus, both after UVX and this alternative cross-linking, rose Bengal cross-linking. So there is an increase in the Young's modulus, and also you can see, as shown before, these areas as we go and penetrate in the cornea that have been affected by cross-linking. We found an increase in the anterior part of the cornea, or even more extended after application of both cross-linking alternatives. So an effect of cross-linking shown up in terms of mechanical properties from OCT plus air puff deformation, OCE, and also on the collagen arrangement. Okay, so we've talked about the cornea, right? Using OCT, using aberrometry, using OCT combined with a stimulus to assess optical properties of the cornea, mechanical properties of the cornea, geometry of the cornea, and also the microscopic arrangement of the collagen. So I would like now to move to the second lens in the anterior segment, which is a crystalline lens. And for me, I mean, this is really a fascinating element. So the crystalline lens in the young eye can accommodate, right? Has like this property of reshaping upon an accommodating stimulus. It also has a very interesting property, which is a gradient index of refraction. So the lens doesn't have a homogeneous index of refraction. It has this gradient structure in the lens that, as we'll see, confers the lens with interesting optical properties. Also, the curvatures and the shapes of the lens are a sphere, so very sophisticated optical element. And I will be showing how we are assessing the dynamic properties of the lens, the geometry of the lens, the gradient index of the lens, using OCT and using aberrometry, and also what applications can we improve with this new knowledge of the lens. So we talked a lot before on topography of the cornea. Well, with OCT, when you apply this quantification, as I mentioned, you can obtain the topography of the crystalline lens, anterior and posterior. And it's actually quite interesting in the sense that we find astigmatism in the surfaces of the lens. And very interestingly, and this is something that we particularly found in young patients, there is like an orthogonal axis orientation between the axis of astigmatism in the anterior crystalline lens and the posterior crystalline lens. So it's very interesting. It looks like there is some type of compensation between the lens surfaces as far as astigmatism goes. The crystalline lens also has dynamic properties, and I mean, again, this movie is not showing, but the crystalline lens changes, particularly its spherical aberration as it accommodates. So this is the accommodative response of an eye that is accommodating dynamically from 0 to 6 diopters in this staircase paradigm. The focus is moving from 0 to 6 diopters, and you see this shift, particularly in the spherical aberration of the crystalline lens. That, of course, must happen because of the changes in the crystalline lens shape and structure. So, of course, we can use OCT to assess those radius of curvatures. With accommodation, the lens becomes steeper in both anterior and posterior radius, particularly the anterior radius. You can use very simple paraxial formulas to estimate the power change in the lens. And sure enough, when you do that, you find these very typical plots of accommodative demand versus accommodative response, where the lens for perhaps the first 3 diopters accommodates to the demand, but then there is a lag of accommodation. And that's interesting because, I mean, normally this is measured by, using refraction, using retinoscopy, using aberrometry, but you can do that also from directly measuring the lens. In fact, you can measure the lens directly, and this is OCT, and looking at these fluctuations of accommodation, and again using the same staircase pattern. The subject here is accommodating, and we observe these changes. The lens thickens when it accommodates. Of course, there's the changes in the radius of curvature, but there's also these fluctuations of accommodation that actually increase in amplitude when the eye has a larger accommodative demand. So by using these quantitative images of OCT and looking at the dynamic accommodation, we can actually try to understand better accommodation and what happens with these fluctuations, and are those fluctuations something that are kind of a trial and error, or is just a mechanical fatigue of the system. I mentioned about the gradient index, and we have also used OCT to measure the gradient index of the lens. We do that ex vivo, where we take the lens in and actually measure it in two different orientations. When you're looking at the posterior surface of the lens through the anterior surface of the lens, and the index of and the gradient index, it's distorted by both, right? It's optically distorted by the shape and by the presence of the gradient index. Because we're doing this ex vivo, we can turn and flip the lens. So we actually have information on the anterior surface of the lens. So what is remaining is the gradient index. And we use an inverse modeling, a search algorithm that is based on a genetic algorithm, and a gradient index model with 4 parameters, and ray tracing algorithm to obtain and reconstruct the gradient index of the lens. And you see here this very typical parabolic shape of the gradient index. In collaboration with the Bascom Palmer Eye Research Institute, we measured the gradient index in lenses of different ages, ranging from 6 to 72 years of age. And we reconstructed this gradient index, the parameters. There is no systematic variation in the magnitude of the index of refraction in the nucleus or the surface of the lens, but what changes dramatically is the profile. So in the younger lenses, this exponential decay is around 2, meaning a parabolic profile. But then with age, this exponential decay increases, meaning that the gradient index becomes kind of a plateau, right? It's very flat, and then sharply goes down near the surface of the lens. And this has very important optical consequences. So if you have the same shape of the crystalline lens with a homogeneous index of refraction, then the spherical aberration of that lens will be positive. However, when you incorporate to the same shape the gradient index that you measure, the spherical aberration is negative. So very important influence of the gradient index, at least, of course, in the young eyes, where we have this parabolic profile, on the negative spherical aberration of the lens. In additional work, we actually tested many more eyes, again, looking at the changes of radius of curvature and asphericity with age, this increase in the power exponent with age, in this case, 37 lenses, and looking at this effect of a spherical aberration and the impact of the shape and the gradient index on the spherical aberration. So in blue are the calculated spherical aberration of crystalline lenses of eyes between 20 and 80 years of age, should the index of refraction be constant, an equivalent refractive index. When the gradient index that we measured is incorporated in red dots, what you see is that particularly in the young lenses, the spherical aberration goes down to negative values, much more negative. Of course, in the older lenses, because the gradient index is so flat, it's not very different to being constant, then the impact of the gradient index is not as important. But certainly it is in the young lenses. So in the eye, when this is combined with the cornea, in the young eye, the cornea has positive spherical aberration, the crystalline lens has negative spherical aberration. They compensate to produce a pretty good optics. With aging, what happens is that this balance is compromised. The crystalline lens changes because of the gradient index, a little bit the shape, but mostly the gradient index, towards less negative values or more positive values that now add to the positive spherical aberration of the cornea. And this is one of the reasons of the change and the degradation of the optical quality with age. So with OCT, of course, the crystalline lens is only visible through the margins of the pupil. We have developed a method to estimate the shape of the lens even beyond the margins of the pupil. We do that using this database, big database of ex vivo lenses that we have to really reconstruct the shape of the periphery, and then produce like a reconstruction of the areas that are hidden by the pupil. When we do that, and we compare that, for example, to an intersection approach where you would expect just like an extrapolation of what happens in the center in the pupil, and you look at where the two surfaces intersect. The proposed method based on this a priori information on the shape of the lens is actually improved in terms of volume. So much more accurate volume estimations. Of course, doing it ex vivo, we assume that we don't know, but then we can compare with reality. Slight improvement when the pupil margin or the pupil is larger, but actually performing pretty well even down to 4 millimeter pupils. Lens diameter, there is a drastic improvement in the diameter estimation, diameter of the lens with the proposed method. In fact, we can actually represent the lenses in a very compact way through a new base that we have developed, which we call eigenlenses. This is a series of shapes that represent different properties of the lens. We call them eigenlenses, thinking, you know, on any of these polynomial bases that you can combine the shape or the function with a coefficient and build up a lens. So what we're saying is that we need less than 6 parameters to represent a given lens. The first coefficient will represent the volume of the lens, the size of the lens. The second coefficient will represent how round this lens is, and the third coefficient will be representative of the general asphericities and tilts and decentrations, but very few coefficients to represent a single lens. And this is actually helping us in reconstructing lenses and looking at various parameters as a function of age, for example. Here, the changes in the radius of curvature that we've seen, but also the lens thickness, lenses becoming thicker with age, the lens diameter, or the volume, like a linear increase in volume with age. And also with accommodation, now not only restricted to the parameters that we can derive from the center of the lens, visible through the pupil, but also outside of the pupil. And that includes the equatorial plane position. So this shift in the equatorial plane position with accommodation, a decrease in lens diameter with accommodation, a decrease in lens surface area, whereas the volume is constant. So now using OCT plus these reconstruction methods, we really understand processes like lens aging and lens accommodation. And I'll cover this later. Of course, we can do that also in cataract surgery. So this is an OCT image now fully quantitative pre-op, and then it's merged with a post-op. So this is the lens implanted, and you can hear how the lens relates to the pre-op crystalline lens. Of course, the cornea is the same. But using these reconstruction methods that I mentioned to derive the full shape of the lens, in this case, in a cataract eye, preoperatively. So you can probably start thinking that, okay, that's probably good to know, right? How big the lens is, particularly because there is such a big variation across the population, and take into account some of these parameters of the lens to really select the lens that is going to be implanted in the eye. So you may know that one of the main, or actually the main source of error in the estimation of the intraocular lens that needs to be implanted in one eye is actually the estimated lens position, knowing where the lens is going to sit with respect to the eye. And this is normally done actually using two parameters that have nothing to do with the crystalline lens. So the standard formulas use the action length of the eye and the radius of curvature of the cornea. That's it. That's what the majority of the intraocular lens power formulas use. But now with all this information on the crystalline lens, right, we're going to be much more accurate in identifying where the lens is going to fall. And we have proposed this estimated lens position formula that now takes into account some of those parameters like lens thickness, the equatorial plane position. So these 3D parameters of the lens that we are deriving from OCT. When you do that and you compare the errors in the estimated lens position or the errors in the refraction using a standard, I mean, for this purpose, still standard intraocular lens power formulas, just including the new estimated lens position using this additional information, you see that there is a lower error in the estimation of the lens position, and also a higher and lower error in refraction compared to other state-of-the-art methods to produce that number. The interesting thing is that now we have from all the cornea and full anterior segment imaging OCT, we have information in the cornea. We have information on the tilt and decentration of the lens. We even know the off-axis position of the cornea. So we can now use this information to create anatomically correct eye models. And instead of using formulas that are derived from regressions of the population, we can actually build these custom eye models to do a ray tracing and obtain the intraocular lens that needs to be implanted. Not only the power, but now the design of the lens. In fact, when you measure the aberrations of using aberrometry, the aberrations of an eye with an intraocular lens implanted, or you do a ray tracing using all this anatomical information and the design of the intraocular lens, you see that there is we're really capturing the wave aberration very well from anatomical and biometric information. So that means that we can use these ISAT platforms for intraocular lens implantation. Of course, once we have this shape of the lens and we know how it changes with accommodation, we can use it in combination with finite element models, getting data from the literature regarding the ciliary body force, the mechanics of the sonule, the capsular back mechanics, to derive the mechanical structure and the mechanical properties of the lens. In fact, we are using a two-zone lens with a nucleus and the core, and we are deriving the shear modulus of the nucleus and the cortex of the lens. These plots are showing the minima, where the minima fall. Of course, if we have something that is very deep and very sharp, we will have a very good estimation. If we have something that is flatter, our estimation will be poorer. In the majority of the cases, we have a very well-established minimum. And you see, even if this is a small range of age, from 20 to 30 years of age, you see this increase in the shear modulus of the lens with age, both in the core and the nucleus. And those correspond very well to the power change in accommodation from aberrometry compared to the simulations. So again, using OCT now to assess the properties of the crystalline lens, and I've been showing applications in cataract surgery. Of course, the crystalline lens has this very interesting property that we've seen of accommodating. This is lost with age. We're using all this inspiration to generate new accommodating IOLs. Today, the accommodating IOLs that have been out in the market, there is only one has been the FDA approved, have been pretty disappointing in the sense that they're not truly accommodating. Our concept actually has two zones or two elements. One element is rigid, the other element is elastic, and it complies with what accommodation does in the sense of changing the curvature of the elastic component. What is very important in an accommodating intraocular lens that I think has been what has the reason for failure in previous attempts is that we need to engage the haptics of this lens with the peripheral region of the capsular bag in order to capture the forces from the ciliary muscle. And we do that through what we call a photo bonding. The idea being to produce a capsular bag lens engagement in the periphery that we have demonstrated ex situ. So this is a strip of capsular bag. This is the material from the lens, from the intraocular lens. We apply, very much like what I mentioned about cross-linking, we apply the photosensitizer, in this case is rose bengal, we apply green light, and we produce this engagement of the polymer with the capsular bag. We have also proved that, and again, the movie is not showing, but we have shown that in ex vivo, but intraocularly. So the surgeon now is producing a cataract surgery procedure where the lens is inserted into the capsular bag. In this case, the capsular bag was filled with rose bengal, and then a probe inserts light and produces this photo bonding intraocularly. So again, we have used OCT and laser ray tracing to assess the performance of this lens, now attached to, not in the eye, but attached to a stretcher that simulates the forces, these equatorial forces from the ciliary muscle. And what you see here, I hope it reminds you what I've been showing about the crystalline lens, right? So when the lens is stretched, it becomes flatter, it becomes thinner, and the equatorial diameter gets larger. However, when the forces are released, it's maximally accommodated, and it's more curved and thicker and has a lower equatorial diameter. So very much like what the crystalline lens does. The change in power that we obtain from laser ray tracing matches what we were expecting for this material and these forces in finite element modeling. And the change in shape are also in compliance with what we were expecting with the model. So there's still some challenges here. We would like to have a material that produces further changes in curvature, and also we would need a more sophisticated or more localized way to bring in the photosensitizer and the light only to the haptics of the lens. But we believe that this lens, unlike others, does not rely on the shape of the lens, doesn't rely on the capsular bag to mold the lens. And it's a new concept that we hope produces advances into delivering this restoration of accommodation lens that is still missing. Just to finish up, I would like to cover the last of the conditions I want to cover, which is myopia. And well, myopia, I mentioned about this being this axial elongation occurring. We have been looking also what happens with the crystalline lens in myopia. This is just an example of the lens, and this is in vivo, sorry, the cornea. The lens, there's two subjects, it's superimposed, one subject in green, that is an ametropic subject, and one subject in pink, that is a myopic subject. What you see is that the myopic subject tends to have like a more stretched lens. It's flatter and it has a larger equatorial diameter. In the full study shown here with over 20 eyes, we are looking at the correlation of lens parameters with axial length or refractive error. And you see that lens thickness, and this is of course a cross-sectional study in young patients, but lens thickness being higher in emmetropic eyes and then, or shorter eyes, and then getting thinner as the eye elongates. Equatorial diameter also correlated with refractive error. Anterior lens radius of curvature and posterior lens radius of curvature consistent with flatter lenses in myopic eyes, and however the lens volume doesn't change. So what may be happening here? I mean, that's looking at the lens give us some information or some insights into what's happening as the eye elongates. And there's two possibilities, right? Why the lens stretches. It could be a mechanical effect of the eyeball expansion, right? But that's probably unlikely, right? Because then you would expect that would be happening in all dimensions and probably not the lens thickening rather than thinning, right? However, it could be that it's actually an active process and the lens would stretch, but at least partially compensate for axial elongation. And so that's intriguing, and it's interesting to consider the lens in the myopia process that has not very much done today. We can use also these imaging technologies I described to assess what is the effects of potential pharmacological interventions of myopia progression. And we have looked at 3 different compounds. One is atropine, another is latanoprost, and finally, in collaboration with Stewart Therapeutics, collagen mimetic peptides. So what we would like to do is to use our techniques to assess the ocular globe and the anterior segment of the eye, and particularly the scleral mechanics and the scleral collagen imaging to investigate what's happening when myopia develops and when those compounds are applied to the eye. And for that, we're using and resorting to guinea pig myopia models. Those are typically used either in a lens-induced myopia paradigm, so placing negative lenses in front of the eye, what makes the eye elongate, or form deprivation myopia, where we put like a diffuser and the eye elongates as a result of this loss in contrast. We measure refraction. We use OCT to measure geometry and axial length. We use second harmonic generation microscopy to assess the collagen organization. And we use either extensiometry or multimeridian OCE to assess the mechanical properties now in the sclera. So we have been able to reconstruct the entire guinea pig anatomy, fully quantitative, applying the techniques that I described before on the reconstruction of the cornea and the crystalline lens. And of course, we can do ray tracing and measure the aberrations. We have also been looking at the lens shape, full lens shape, in myopic eyes in guinea pigs and their contralateral control eyes. We see some changes like an increase in lens volume, increase in lens diameter, and also changes in the equatorial lens position, in this case consistent with the crystalline lens being larger in the myopic eyes. We have also used the gradient index reconstruction to measure the gradient index distribution in the eye of the guinea pig. And as we found in humans, and it's very much the case across species, we find that the gradient index actually plays a very significant role here too, to decrease the spherical aberration of the eye. So again, if you had a homogeneous index of refraction, you would have massive amounts of spherical aberration, particularly in these eyes that have like more rounded lenses. But then the gradient index makes the spherical aberration shift even to negative values in the young eyes. In the myopia induction paradigm, we put the goggles in one eye, and then the other eye is left as a control. In a set of eyes, we either use a sham BSS on top of the myopic eye, or latanoprost or atropine. And we do that over the course of 10 weeks, and we measure in vivo using OCT and the structure of the eye. And at the end of the treatment, we look at the sclera ex vivo. So what we found is that myopic eyes, as expected, increase the axial length with respect to the contralateral non-myopic eye. Their eyes develop myopia up to about -6, -8 diopters in the course of 8 to 10 weeks. And what we've seen is that particularly latanoprost here in red produces a slowdown in the axial length expansion, and also a reduction in the induced myopia by about half of what you find in the other cases. Atropine, we didn't find that to be very effective. However, latanoprost was clearly and significantly reducing myopia progression. So in terms of the scleral elasticity, we found that there is a stiffness variation in the myopic eye. The myopic eye having weaker and more elastic scleras by a factor of 3 in the pure myopic and treated with just a saline solution. We find some variations in stiffness to reduce or increase stiffness in atropine with respect to the contralateral eye or to the myopic eye and latanoprost. So even if in all cases there is a stiffness variation with respect to the non-myopic eye, latanoprost in particular, a little bit atropine, also produce some slowdown in this stiffness variation compared to the fully myopic eye. And that has a consequence on the collagen organization. So we find that unlike in the myopic eye without further treatment, where we see a difference in the collagen organization with respect to the control eye, the atropine and latanoprost show very similar organization in the collagen orientation, suggesting that we're acting on the sclera somehow to reduce the increased elasticity. It's known that in myopic eyes, there is an increase in MMP2, which is a collagenase type. And in recent work, we have been looking and using this second harmonic generation microscopy to see the effect of collagenase on the eye. And what you see here is that in scleras treated with collagenase, there is a drastic change in the organization of the collagen. The collagen fibers being like more sparse and traveling in a more unique orientations as opposed to before treatment, where there is a higher degree of interweaving. We have treated those scleras with a CMP, which is a collagen mimetic peptide. And what we're saying is that the collagen mimetic peptide restores the interweaving that we're finding in the virgin eye. And this is shown here in terms of this coefficient that describes the order of the collagen fibers as a function of depth. After collagenase, this is increased over a range of about 60 microns, and then with the application of the collagen mimetic peptide, that goes back to normal virgin arrangement. Yeah, that's how I wanted to finish up the myopia work. So in a nutshell, I hope I give you like an overview of these anterior segment imaging technologies and how we're using them to assess cornea, crystalline lens, and their changes with accommodation, aging, and disease, covering keratoconus, cataract presbyopia, and myopia. And I thank you very much for your attention.
Susana, thank you so much. We will go to Tony at the end. Tony, you will be the final comments and overall view. Today also is our last seminar before summer, and we will rejoin in September. And I wanted to start with a very simple question, and we have more questions from the room. That I always was puzzled, and I don't study lens cornea, so I don't know much. Typically in biology, when you have stiffening, you have cross-linking. That's a very, very bad thing. And cornea people are using this cross-linking as a what? What does it do, and how harmful it is, and how good it is?
Yeah, no, I totally agree. I mean, this is a technology that actually has been used in Europe for keratoconic treatments for about 10 years or even more. It took much longer to be FDA approved. It was finally FDA approved. It seems to work in patients, but I think there's major gaps of information, right? One is what happens really with keratoconus. I mean, it's keratoconus. What is failing in keratoconus is the collagen fibers. It is the hydrogel where these collagen fibers are embedded. And likewise, cross-linking. I mean, what is cross-linking doing? Is cross-linking creating these covalent bonds between fibrils? It is creating intrafibril bonds, or is it affecting the intracellular matrix? So those are very interesting questions. And I think what is very interesting is that the different techniques that we have to now, for the first time, even in vivo, assess the cornea and cross-linking and keratoconus, is that the information that maybe derives from those may be very complementary, right? I mean, we may be looking at the Janus modulus in an air path deformation, whereas we may be looking at the shear modulus in OCE. And those may be affected differently by the collagen fibers and the intrastromal matrix.
Okay, thank you. Vladimir.
Yes, hi, Dr. Marcos. Very exciting and impressive technology and a great talk. A couple of questions. One is very basic, which is how do the measurements of your corneal mechanical properties vary with age? Have you or anyone looked at how the cornea changes as we age? And are those measurements affected by intraocular pressure, that fluctuates? And my second question is more practical. Can you use this really high-end imaging in real time during surgical procedures to help with those?
Mm-hmm. Yeah, very good questions. So we haven't measured changes with aging in the cornea, but as you say, that's something that we expect the cornea to stiffen with age. I mean, it's like this natural cross-linking happening over time. So we would love to measure that at least cross-sectionally. So we're gathering, particularly with OCE, we're gathering baseline data. At this point, they're pretty compact in terms of age range, but we'd like to extend that as a function of age. Second question was there was some
surgery, yeah. During using the method during surgery to guide surgeries in real time.
Yeah, that would be ultimate, right? I'm thinking, for example, in cross-linking. Cross-linking right now is, of course, there is no measurement done on the corneal biomechanics to assess, the cornea, and cross-linking right now is done over the entire cornea. So potentially cross-linking areas that are weakened, but also areas that are stiffened. So you would think that localizing the treatment would be better, right? So this is something that you could do, if not intraoperatively, at least preoperatively, to assess which areas should be stiffened, right? In a more customized way to the cornea. So, so I think you're right. I mean, eventually doing something intraoperatively could be interesting, but at least having these as a tool for planning, that's our more immediate goal.
Thank you.
Dr. Shaw.
Yes. Susana, can you hear me okay?
Yeah. Mm-hmm.
Great, great. Thank you very much. I'm a pediatric ophthalmologist here at UCI. And sorry, I only caught the last 20 minutes of your talk. And by the way, it's fascinating, fascinating. So I do research on myopia progression in pediatric patients in humans. So two questions. The atropine that you used, of course, it works in humans, in pediatric patients. Why do you think, although it had an impact on the rigidity of the sclera, why do you think that it didn't have an impact on the myopia? And second, what concentration did you use?
Yeah, that's a very good question. And we actually, I mean, the answer is we don't know. I mean, certainly we found those trends in the sclera. We were hoping the atropine to work, but we didn't find this mirroring in axial elongation on or refractive error, and we don't know. And as you point out, it's maybe the concentration of the atropine. It may be that, you know, we should change the atropine in a way that is not similar to the cornea, to the myopic patients, which, I mean, by the way, we were using the clinical formulation. It may be that it's just a question of dosage. We don't know, but truly it's a technique, or it's a treatment that we would like to investigate more. Not only in our animal models, but also, as you say, it's being used in a human pediatric population. I don't know if you get to my talk where I was talking about the crystalline lens, but it would be really interesting, I think, to see what happens with the crystalline lens as the eye elongates, both in humans, in myopia, but also in myopic children that are undergoing atropine treatment. So really trying to understand, I mean, how the eye expands and how the cornea and the crystalline lens and axial length interplay in what we are observing.
Thank you.
All right, let's go to John and Cesare, and then we'll go to Zoom.
Hello, Dr. Marcos. Thank you for this great presentation. I was wondering if in pre-cataracts or with very mild cataracts, the material nature of the lens changes, or if that's observable in maybe the Young's modulus, or maybe tensile strength of the lens changes, or if there's an association with shape and volume that is associated with the formation of cataracts.
Yeah, very likely. For the purpose of the study, where we were looking at accommodation and using the natural accommodation, you know, as a stretcher to assess the mechanical properties of the crystalline lens, we need accommodating lenses. So this is something that we couldn't possibly extrapolate to older eyes. But when you look at the gradient of the density changes, it parallels very much the gradient index distribution. It also parallels the mechanical properties. So I'm convinced that those observations continue until the presbyopia and cataract.
Hello, my name is Cesare Rez, and I'm a postdoctoral researcher. I have a question regarding corneal transplant. The eyes that have been transplanted, with cornea. Have you looked into the biomechanics of this? And my second question is following up on Dr. Kefalov's and Dr. Sa's questions. I would like to know if you look at corneal biomechanics in very young individuals, infants or young children in pediatric population, and how it changes from, how it is different from the corneal biomechanics in adult population, for example.
Yeah, so I mean, starting with the second, I mean, that goes in the aging, right? It's actually very, I mean, it's very recent that we have the ability to do these measurements in vivo. I mean, really what I showed you are the first measurements. It's great that we can produce these maps, and it's a very non-invasive technique. That opens all the possibilities that you're saying about measuring, you know, like different ranges in the population, different diseases. So that's something that is up still to do, because it's only very recently that we have produced this capability of producing these measurements in vivo. As far as the sample that was taken from a penetrating keratoplasty, we only measure the collagen arrangement. Those was done using second harmonic generation microscopy, and this was fixed tissue. But now we're arranging the possibility to get this tissue fresh, because the surgeries are done in the 3rd floor, and it will be taken down to our lab in the 1st floor. So the idea with that is to produce both mechanical measurements of these tissue extracted from keratoconic patients, as well as the second harmonic generation for the collagen arrangement. So something that we didn't do because we didn't have the opportunity to do that, but it's on the plans.
Thank you. I have one super quick follow-up question. Have you maybe worked with, have you maybe assessed patients that had non-perforating keratoplasties, like for example, decimate membrane transplant?
We were not looking at the patients after the transplantation. I mean, those patients actually what we use was the portion of the cornea that was extracted during the surgical procedure.
Understand. Okay, thank you.
But I mean, of course, with OCE, we can bring patients after any kind of corneal procedure.
We had a wonderful conversation. The last question go Maciej, and then final comments, Tony.
Okay, just quick question. Thank you very much, Susana, for the talk. And I'm always, you know, very inspired by this work on ultrasound, and so the ultrasound excitation of lamp wave must be a nonlinear process, right? And it doesn't cause much of fatigue to the eye when you use this method. So is it beneficial to repeat many times the measurements with different amplitudes to get a little bit more sensitivity or specificity of this technique to little bit make the cloud of points, you know, narrower in this parametric space?
Mm-hmm. I mean, we're doing, I mean, it's basically like a sweep, right? So and we take different meridians. So I don't think I mean, we find actually very symmetric in normal eyes. Those points are very symmetric. The cloud that I show corresponds to, you know, like many patients, normal patients, and it comprises points along all these different meridians. When you go to patients that have keratoconus, then is where, you know, like these constellations, we call them, start to get elongated, right? Or asymmetric. So, I mean, we may explore other ranges, other frequencies, and other paradigms of excitation. So far, this is working for us very well. It's within the range where we have good sensitivity, and it's completely mild to the patient. I mean, the majority of the patients actually don't notice anything whatsoever being, you know, exciting the cornea, which makes it very attractive from the point of view of a clinical instrument. The other thing that I think is very interesting is that this is a module that we could couple to any OCT. I mean, you just get and this is how we did with our system. It was initially a regular OCT, phase sensitive mode, and we put the excitation module. So conceivably, these could be brought to other instruments and be brought to the clinic without the necessity to have an entire new instrument.
Exactly. So I think this will be a really big step in towards the biometrics of human cornea. It's really, yeah, that is something what can change this all instrumentation, so paradigms. Thank you.
All right, let's go, ladies and gentlemen. Now I give you Dr. Nesburn.
Well, Dr. Marcus, I am an anterior corneal, an anterior segment surgeon, the only one I think in our audience. And I've got to compliment you because you and your colleagues are now bringing science to so many of the things that we've been dealing with clinically. And I'll just point out to everybody, myopia, we talk about translational medicine. There are millions of people worldwide becoming myopic, and we now are beginning to get tools to be able to study this. And in terms of keratoconus, I'll just comment on that. Keratoconus was a major thing I dealt with in my life in patients, and cross-linking is safe and seems to be working very well. The problem is it's like shooting gnats with a blunderbuss. It's a terribly widespread technique, and the newer people, Dr. Jester, who's in our faculty, is coming up with a pinpoint method to do treatment early, and we're hoping that some of the pictures you showed of early keratoconus in the other eye, that would be perfect to be able to treat locally, you know, and stop the progression of the disease. The other thing that's really exciting to me that is post-corneal transplant, one of the major problems that transplant patients have is that they end up with high errors of astigmatism and the rest that you can't predict ahead of time. And to be able to use some of the tools you have, you know, in order to correct that would really be a major help to patients. Anyway, congratulations. I think it's a wonderful talk, and thank you for bringing it.
Thank you, Tony. Thank you, Susana.